My name's Dan Thorpe. I'm the mental health lead for the Met Police, and I work quite closely with the College of Policing, or very closely. I'm actually standing in for Michael Brown, who looks completely different to me, but Michael and I work very closely on this, and we have done over the last 2 years, with a fair few of you from the audience actually that I recognise. So it's great to be here. I've got a lot to talk about, so you're going to have to hold me to those 30 minutes. There's an awful lot to get through, but it's positive stuff. Yeah. What the hell's this got to do with what I'm going to talk to you about? It's an oil tanker in the North Atlantic Sea. I've used a different photo, but when I've spoken at a National Concordat event, I've used this to describe how it feels sometimes to lead mental health for the Met Police. And I know, speaking to other colleagues that are in a similar position to me, they feel a bit the same. In London especially, we've got 10 mental health trusts, 32 local authorities, 32 London boroughs obviously, and various other partners. And to actually steer a change in direction can be really a challenge. And that is testament to what I'm going to talk to you about next, because this has been 2 years in the making, but it's been a really productive 2 years. So in autumn 2014, I hosted a meeting at this place. This is the Emperor State Building, which is one of the Met Police buildings in West London. And I invited a lot of London and national sort of leads, including representations from the Home Office, Department of Health, and various other areas of government. And the whole purpose of it was in response to a number of deaths following police contact around mental health, certainly around mental health crisis. And we wanted to do something about it. And this is shortly after the Commissioner of the Police invited Lord Victor Adewale to do the Independent Commission on Mental Health and Policing. And it was obvious from that, and it was obvious anyway, that we needed to start the conversation about mental health and restraint. And I'm going to talk to you about from very much a police perspective. Realising early on that what we were discussing in London and the challenges that we were experiencing, that is no different to elsewhere in the country. They were experiencing exactly the same thing. And this is why Michael and I, and Michael was just, I think, about that time, moving from his force into the College of Policing. And that's how he and the college formed a very close link on this work. And why is the work necessary? These are just a handful of names. There could be so many more of deaths. And we owe it to those families, the friends, the carers, and the people that have died in tragic circumstances to look at this in some detail. And this has been quite an intense journey, quite a challenging one. But how beneficial is it going to be when it comes to fruition? I'm going to talk about that in a minute. Now, most of you will be familiar with the Codes of Practice, the old one in 2008, that very much talked about, and that's the paragraph that's relevant to this, is the exceptional times that police get called into a mental health hospital. It was mentioned then, and it's been mentioned in the new one that actually the police were very much involved with the Department of Health and the Home Office. And that paragraph's been expanded somewhat. I don't intend you to read that now, but that word exceptionally remains in there. There are obviously other documents. Norman Lamb mentioned some of these already. First of all, the NG10, the NICE publication. Again, I don't expect you to read that, obviously you probably know it already. But in there, and the Positive and Safe Department of Health document that was published that Norman Lamb had so much to do with, they both talk about how important it is to have local protocols or understandings with the police around when, very exceptionally, they would step foot in a mental health hospital and exert some form of restraint or control. Now, you showed this. That's impressive, isn't it? So we formed the National Mental Health Restraint Expert Reference Group as a result of those discussions that I had at the Emperor State Building. That is not a meeting of the National Mental Health Expert Reference Group. But the reason why I put that up is look at that collaboration, that partnership working. I find that photograph absolutely amazing. And that was, I can't even read it from here. Where is that? That was in Barcelona in Spain. About them all working together to achieve that. It's a similar sort of thing to what we were doing in the National Restraint Expert Reference Group. We decided early on to concentrate on 2 areas. Phase 1 is more or less complete. And it's to look at the police use of restraint in mental health settings. Phase 2 is to look at police restraint with people with suffering from mental ill health elsewhere. So that could be your EDs, emergency departments, out in the public, in a private home, etc., etc. That is about to start, phase 2. These are just a few of the organisations that we were working with over the last 2 years. There are too many to put on there. But we realised very early on that it shouldn't be the NHS or the police or the College of Policing or any other partner that should chair that. So we asked Lord Carlisle to independently chair that for us, and he's been a real ambassador to drive some of this work forward. So let's look a bit more closely on phase 1. We were concerned around the complete differences across the UK about how the police were being used and how many times police were being called in to mental health hospitals. It varied considerably. And we started asking ourselves some quite searching questions as a result of this early work. I don't need to read all of those to you. I'm going to touch on the consistency bit in a minute in a bit more detail. That question at the bottom was really quite interesting. Do we really understand the risk? And to give you an idea, we visited Broadmoor Hospital. I've been there once before, but we as a group went there, and we spent the whole day there, and that was really interesting. Because what we found out is obviously they're dealing with high-risk, well-known individuals, but to accompany that risk, they had very well-trained members of staff. They even had mock-ups of a building where they practiced in stairways that were exactly the same as what they had in Broadmoor Hospital, and wards and everything else. Is that where the highest risk is? And then you compare that to a community inpatient setting, outpatient setting, a 136 suite as they're known. Is that where the risk is? Where you don't know who you're dealing with? I would say that is where your biggest risk is. That is certainly where we get called. We hardly ever get called to Broadmoor Hospital. And we found that quite an interesting but not unsurprising dynamic. NHS Protect, this is on the backdrop of their own statistics. That's what they're quoted. I don't know how many of you are aware of that, but when I first saw that a few years ago, I was quite staggered by the sheer volume, which just identifies the challenge. Just going to touch on phase 2, which we haven't started yet, but in my opinion, because we get to have these conversations, is that this is very much a whole systems approach for phase 2. Restraint outside of a mental health setting, outside of a setting where we manage and treat and coach people with learning difficulties. So this is everywhere other than those. What do I mean by a whole systems approach? Well, take beds as an example. We know, and I've read so many different reports, but roughly, I think between 2008 and 2012, we were looking at around 40% reduction in beds. That's what various reports that I've read. In London, this is NHS London's figures, not mine. We're losing around 5 to 6% of mental health inpatient beds in London each year, and I would argue the demand is going up. Now, I could stay here and debate all day around what level of beds should we have, but actually when that's reducing and when community mental health teams are up to their eyeballs, I think we've got a bit of a challenge. And it's certainly something that I'm passionate about unblocking and having a discussion about, which is why things like this is so important. Just to give you an idea, and this is a bit of a crude measurement, because police operators taking 999 calls have to make a judgment within a very short space of time. But we respond to about 200 calls a day just in London around mental health crisis type incidents. 50%, no, not 50%, 25% of those are to NHS premises. And that could be for a range of things. That could be for reporting a crime, reporting a missing patient, and it could also be to assist staff control patients. Whole systems approach. I know some trusts, certainly in London, are really pushing forward with providing a 24-hour rapid response. And there's one thing that I asked for about 2 to 3 years ago when I spoke after the National Crisis Concordat was launched. If there was one thing that the police would want, what would it be? It would be access to 24/7 mental health professional support. And we're coming a long way in relation to that journey. But I do have a question mark because it is inconsistent in London, and I'm sure it's inconsistent elsewhere in the country. But this is why it's important that we get together and we work out what works and what doesn't. And I know those conversations that have been taken place. Let's just look at the range of things. How am I doing for time? Am I halfway there?
You're fine.
A range of things around what police get involved in. Talked about, obviously, our interactions with mental health hospitals. Ambulances. I don't know whether any of you saw the BBC One documentary on the London Ambulance Service, which I thought was actually done really well. And I think it's really good the public see the challenge. But that gives you an idea of what the challenge is, which I know you're probably all aware of. But we in the police service, when we call for an ambulance, it's not unfamiliar territory that there are no ambulances to send. So we end up transporting people that we detain under 136, of which I've already shown you that the demand is quite considerable. And that can present issues for us around restraint. We know in London, the London Ambulance Service, now recognising issues such as acute behavioural disorder, they have 3 advanced paramedics that are able to use tranquilisation, very much to save life in various scenarios. So there's a lot of work to unplug, and we continue. I talk so highly of the LAS. I think they do absolutely marvellous job, and they have our absolute support. But there are some fundamental challenges there. And when you think about restraint, if we now restrain somebody that we detain under the Mental Health Act, and we want an ambulance, we need an ambulance, they should respond to that within 8 minutes if there is ongoing restraint. And that, again, is a step forward about how things are prioritised. GP areas, how easy is it for them to have access to mental health services? I know of occasions in London, fairly infrequent, but they still happen, where GPs really struggle to get access to mental health services. Really distressing patients come into their surgery, things get escalated, and before you know it, police are being called. And police officers are choosing whether to detain under the Mental Health Act or not. Accident and emergency. Interesting that accident and emergency don't have any powers, really, to manage people that enter accident and emergency for mental health crisis. Did you know that in London, we the police, the Met Police, we take 450 people on average a month, urgently seeking crisis care, voluntary, to an ED. So big issues there. Private residential property. We have no powers to deal with mental health crisis in a private address. No powers whatsoever. Yet we respond to those calls hundreds of times a day, if not a month. Issues there around the use of restraint. And our Commissioner is being quite aggressive around officers having body-worn video. We are starting to see some really shocking things around what they are dealing with, around people in psychosis, suffering from certainly drug-induced psychotic episodes in their private addresses. And then officers having to manage that with no powers. Interesting, when you're talking about restraint. Care homes. I know there's a lot of talk, there certainly has been in various social sites around community care. I think they have a site around the huge volumes of Dole's assessments that are going through the system. Please get called to people that are waiting a deprivation of liberty safeguarding assessment where they're struggling to deal with people. Please get called to that. So you see phase 2, will that take longer than 2 years? I think it might do. There's lots to discuss. Another thing that was interesting, certainly in my experience, and I've got 22 years service now, certainly when I was a junior PC, I remember responding to requests for help from mental health hospitals. I thought nothing of it. I thought that was part of our role. Did it pretty much every other day. And actually, when you start writing things, we have to justify everything, obviously, in our notes. And you start thinking, well, what powers have I got to do X, Y, and Z? From health staff, from police? The often answer is that, don't worry about it, you're covered under the Mental Health Act. Are we? Actually, this journey that we've been on says that we're not. So yeah, there's a big question mark around that. There's also, talking about the inconsistencies, there's certainly occasions, and I'm going to give you one occasion, that involved a coat hanger. 999 call. Patient detained under Section 3 being cared for in a mental health hospital, armed with a coat hanger, threatening staff. We turn up, look at CCTV. When we turn up, the patient is sitting there calmly, just like you are, holding a coat hanger. On another occasion, 999 call goes in. A mental health patient has got a member of staff, nursing staff, in a headlock, stabbing them repeatedly with a biro pen. Police chose not to respond because they thought that was the responsibility of the hospital. This is why this work is so important, to get consistency and to make sure that we're aware of each other's responsibilities. This journey also made us look at things like the Health and Safety at Work Act. And actually, the responsibilities under these pieces of legislation that you as an NHS employer, your employers, have for you, the people that visit hospitals, so that includes the police, and actually your individual responsibility around health and safety. And we very much looked at that, and where does the steps of an NHS trust lie with their staff about taking reasonable steps to protect people under your care. Going back to phase 1, which is due to be launched by the College of Policing hopefully later on this year, it very much clarifies when police should become involved in a request for help inside a mental health hospital. And it covers things like these that are fairly obvious. We do have a role to support NHS staff. And that issue with the biro is just one illustration of why this is important to get right. This is the first time that we've got this sort of agreement, or we will have this sort of guidance out there. I'll give you another example about some of the challenge around phase 2. Is police deal with detain somebody under 136 for whatever reason, and this is not a criticism, for whatever reason they get refused access to a mental health hospital, they are full up, for example. We divert to an emergency department instead of a police station, because an emergency department is a far better place than a police station. And we get refused access because we still get consultants saying, well, there's no physical issues. Not in my emergency department. So we then take them to a police cell, where on some occasions they do need ongoing restraint to prevent them hitting their head against the floor, self-harm. Is that the right place for people detained under the Mental Health Act? Now, I know there's been huge drive forward, and certainly in London, we've reduced our 136s going to police cells by 80% in the last 2 years, which is great, but there's still work to do. Again, for phase 2, that's a lot to discuss. So yeah, we need to work in collaboration, and there are some helpful things that have started to come through. Nice guidance, as an example of that. Talks for the first time around EDs, not turning people that are violent out. Actually, there's a role to be played here. Also, and we've worked really hard with and closely with the Royal College of Emergency Medicine. In May this year, they issued some guidance around that phrase that I said earlier on about ABD, acute behavioural disorder. Do you know, I remember going into emergency departments saying, I think there was a couple of terms being bounced around, excited delirium, people have heard of that? The now recognised term is ABD. I remember having conversations with consultants who said, well, I don't recognise that. Excited delirium, what's that? ABD, what's that? Well, now there's some national guidance about how A&E should treat it, which is really great because we're seeing these cases go up. So there's some really good stuff going on, but there's still work to do. If we look at the legislation, I just wanted to point this out about what the challenge is from, again, my point of view, the police's point of view. This is what the law says about place of safety. We should use it as police stations as a last resort. That's a quotation from a Home Office report when we got into reviewing the legislation, which is due to be published next year under 135 and 136. It's there for all to see. So we're still under a lot of discussion with the Home Office and the Department of Health about getting into the detail of what's going to be in the new revised Mental Health Act when you talk about 135 and 136. But this is what we need to talk about, the bit in red. So police cells can only be used if the person's behaviour is so extreme they cannot otherwise be safely managed. We train our officers to avoid things like that and all those names that I put forward and displayed. And I question this. If you look back as far as the case of Rocky Bennett, that had nothing to do with the police, by the way, those of you that may or may not be familiar with it. There's some quotations there about restraint and when that should be a medical emergency. So what are we learning about that? When someone is so extreme, we're taking somebody that is a medical emergency to a police cell. We even have our own IPCC that's got a view around the use of police cells. So phase 2 is going to be an interesting journey. But it's so important that we have these conversations because we need to learn from it. We also train our officers to do that. If they are detaining somebody under the Mental Health Act and they have to perform ongoing restraint, that is a medical emergency. Someone so extreme, do they need ongoing restraint? I would say so, sometimes. Certainly to prevent them committing self-harm on themselves. That's a medical emergency. We do not want them in police cells. It doesn't get much better than that. Come on. You are nearly there. I'm nearly going to... Your 5 minutes is nearly there. I'll give myself the warning.
You've got 6 minutes.
There's just a couple more slides to go. The Phase 1 publication that is due to come out later on this year, it's going to cover some of these things, which I think are very important. For the first time, we have a document, an agreement that clarifies what our powers are. So it's not about just the Mental Health Act, because the police have very limited powers under that. Yeah, we have powers under 136, but Section 136 is a preserved power of arrest under the Police and Criminal Evidence Act, which gives us powers under that to restrain, not under the Mental Health Act. So what does that mean when you are dealing with somebody detained under Section 3 that needs to be restrained and you're calling for the police? Well, that's what this is going to clarify, what powers we've got, which will give us all confidence about what we can and can't do. There is some great work going on. Take street triage. You know, I'm a bit mixed about street triage, but regardless of that, it's still achieving some good things. If anything, it's bringing us closer together and making us work in partnership. Single points of access. Certainly in London, we've got mental health trusts that are introducing single points of access that are opening up to emergency services, so not only the police, but the ambulance services as well. So when we are dealing with somebody in crisis out there in the street at 2 o'clock in the morning or in their private address, we phone through to that and get the mental health professional support that we need and what I asked for about 3 years ago. So again, that's a huge positive step, and I know there's great stuff going on elsewhere in the country. EDs, latent psychiatry services. I know, for example, in London, they are really focusing on funding for that and providing not only Monday to Friday, 8 till 5 cover, but 24-hour cover. And that will be a huge step forward. Bearing in mind, those 450 on average people that we take, they're voluntary. And there's also some really good stuff. Actually here, Birmingham and Solihull, around their psychiatric decision unit, we're taking the learning from that and we're opening, I say we, well I think it is we, it's not, the NHS in a South London trust is opening their first psychiatric decision unit, taking into account the best practice that we've seen in Birmingham. I think that's absolutely brilliant. So let's see how that works, and then I want to see how we can roll that out across London, so we're influencing each other. And I've already mentioned the work around the Royal College of Emergency Medicine. So that first photo that I showed you, are we now settling towards that? I don't know, I'll leave that for you to decide. But the one thing that I will say is that it's so important that we continue to work together. Thank you very much.